point, the patient has had a CAT scan, let's say, shows a lump, and she's going, oh, because she's opened the report,
Yep,
because
should.
people should, and she's going,
No one else
oh,
is.
shit, what's my lump? Now, if you're referred to a respiratory physician, let's say the patient was 15 years younger, non-smoker. Would you ever say, on seeing a lump, 2.5 centimetres or something, oh, we'll have a look at that in another 3 months' time?
Patient came with a chronic or progressive cough like this and hemoptysis, we would pretty much always say that this is a pretty suspicious situation and we would want to get to the bottom of it. Yeah.
And would you say, oh, come back in 3 months with another CAT scan?
Oh no, sorry. I mean, we would want to get on and investigate it. Yeah,
well,
now.
That does still happen out there a hell of a lot. Oh, no, you don't smoke. No, you're young. You're quite fit.
As we said before, the pattern of referral is variable, and sometimes it goes to Michael as an oncologist or the radiotherapist or the surgeon. They look at it and think, this is not a cancer problem, and then it comes to us. And other times it comes to me first, and then it goes to them as the cancer treaters, I guess. Yeah.
And sometimes it depends on how pushy the patient is.
Yep.
When they're the one with a lump.
And you're right. And from time to time, you see someone who has been told to wait and have an X-ray in another 3 or 6 months, and yeah, I mean that certainly.
But by the time you get to the point where you've got a CT scan with a lump on it, then you are into the province. If there's any sort of question about what should be done, and in my view there probably isn't a question, but if there is a question, then you are into the province of a multidisciplinary team, because you really, before I think you decide that you're going to watch a lump in someone's lung, you want to make sure that there's not a whole lot of other people who think it should just be taken out or biopsied or investigated further in whatever way appropriate.
I think that Michael's point about gateway is also relevant for where you work. If you work with a good MDT, anyone who's on that MDT will be the gateway into that MDT.
Okay.
So it's not as relevant. If you're not a part of an MDT, which sadly some lung cancer specialists aren't, then it may be more important which gate they go through, because a respiratory physician may do more appropriate investigations if they went to a radiation oncologist who isn't part of and that's a very rare breed, but the gateway is important in your context.
Is it routine to have a respiratory physician on your multidisciplinary cancer?
Oh yeah, yeah.
Is it routine to have a GP?
Just a question for Mary. I know you brought up, the others mentioned the fact that we didn't have a diagnosis yet, so obviously you wouldn't introduce a lung cancer nurse because we don't know it's lung cancer, but do you feel that often your role is introduced too late so that you're not able to coordinate that early on to try and relieve patient anxiety?
No, in my practice I don't, because I actually triage the referrals that come into our multidisciplinary team. So my contact in my practice with Cathy would be when we got the referral from the GP, and I would have had a phone consultation with her before she arrived. So no, I don't think we're introduced too late. But again, the points I was making earlier, and I take everything the medical clinician said, is the importance of having somebody involved very early for access is really important, not just for the patient and the family, but for our colleagues in the community. But we are introduced quite early in my practice.
Chris, how soon can a patient get into you with this presentation?
We have the same. I think generally we have the same approach. If it's a suspicion of cancer, there's a lot of anxiety related to it, and people want to get on and get it dealt with quickly. And we would generally try and see them within a few days to be realistic. That week, if at all possible. Sometimes it's not possible, and early the next week, but within that sort of time frame.
David, where are you, and why is it that GPs don't ring you?
They do, and with all my GPs that regularly refer to me, I tell them, call me, and when I give my talks and things, I ask them to call me, or call my secretary and leave a message for me to get back to you. And at the end of the day, you've got your 30 phone calls that you have to get back to, and you do. If that's an inappropriate delay of 6 hours, then I don't, I'll still see them the next day and contact the patient. But the GPs sometimes don't call, and that comment of the 3-month CT, if you'd called and got advice, you wouldn't have left it for 3 months, but a lot of GPs don't call.
Respiratory physicians, probably at POW, would see people within 2 to 3 days because...
2 to 3 days.
But my colleague who would see you within the hour wouldn't be here because he's working in private practice and he would see somebody that afternoon.
Chris, so I'm going to bring Cathy round to your office. Have you got the information you need?
The most important thing I need is the CT. I need to know what the CT shows. Oh, thanks. So what I would routinely do is have a look at things before the patient comes in, and I would put the CT up next to my desk, and I would generally discuss the CT with the patient during the consultation at some time, depending upon when was appropriate. Yep.
Okay.
Hi, Cathy.
Hi.
I'm Chris Dennis. Very nice to meet you. I've spoken with Dr. Wilcox, who's told me about the situation, and I've had a look at your scans, which are up here behind.
It's been a dreadful 2 days. My mind's been going, I've got cancer or haven't got cancer. I can't have cancer, but, oh, it's been awful. So if you can give me any...
Could you start by just telling me a little bit about how things have evolved over the last few months with this problem?
I've had this cough that I couldn't get rid of, and my GPs obviously gave me antibiotics to begin with, and they sent me for an X-ray and then a CT scan because it just wouldn't go, and then I was coughing up blood, and they finally sent me to you. So
Yep.
I'm just going a bit crazy at the moment.
You're a bit concerned. And what is?
Yes.
And what did Simon say to you about the problem, and what information has he given you so far?
Well, obviously we looked at things like pleurisy and pneumonia first of all, because I can't see how I can have anything like cancer. I don't smoke.
Right.
I don't live in a smoking atmosphere.
Right.
I live in Mosman. I work in a fairly clean library. It's a music library. It's not dusty like books. I can't possibly have got... it's not in the family. My father didn't die of lung cancer. I'm trying to convince myself, basically, doctor. I'm trying to convince myself that I can't possibly have lung cancer.
Yep. And what's your understanding about why you've come to see me and my role in this?
That you might be able to find another reason in the respiratory tract that is going wrong. I mean, my father was always chesty.
Yep.
Is it something to do with that?
Yep. Yep. Good. All right. No, that's fine. I think I'll need to examine you in a minute. I know Dr. Wilcox has, but I will as well. And we'll have a look at the CT scan together.
What does that actually say, that scan?
Yeah, the scan shows that there is a lump in that right lung of yours that might be the source of this bleeding, and that's...
Is that cancerous?
Well, that's
Or
the
can it be benign?
question that I've got to answer, really.
You can't answer it.
I can't answer it just talking to you and looking at the scan with any certainty, and we have to figure out how we're going to be absolutely sure what this is.
And what does that entail?
And normally that would mean that I would have a look down with a bronchoscope, which is an instrument to look into your lungs. We will, before we do that, just this afternoon, we'll get some sputum. Are you still coughing up some sputum?
Yes.
We might send that off and look at the cells in the sputum, and I mean, that might help us. We could do that this evening. But otherwise, looking at your scans and talking to you, I think we should organise for you to have a bronchoscopy tomorrow morning.
What's your gut reaction?
What's my gut reaction? My gut reaction is that we need to do the bronchoscopy, and I think that's what's important at the moment. Is it something that we should be worried about? Of course it's something we should be worried about, and I can sense how worried you are, but I think before we I guess worry too much, we should get on and find out exactly what we're dealing with here, and then we can have a plan.
And the
from there.
bronchoscopy will prove that fact, whether it's cancerous or not.
The bronchoscopy, I think in this situation, having had a look at your scans and you can see this little lump here, I think the bronchoscopy stands a very good chance of giving us the answer.
But you're not being absolutely definite.
Well, not many things in life are absolutely definite, are they? And I think that we should do the bronchoscopy. If that doesn't give us the answer, there are other ways of getting the answer, and we will get the answer.
So exactly what can you do to give me a definite answer? Can we jump the bronchoscopy? Can we jump something else and go straight to the test that is going to tell you that I've definitely got lung cancer?
Well, I think we should just do this in a sensible fashion, and we should do the simplest thing that's at least risk, that's going to give you the least risk and give us the best chance of obtaining the diagnosis, and that would be a bronchoscopy.
So if the bronchoscopy doesn't tell you definitely what I've got, what is your next step?
Our next step would be to put a little needle into this area on your chest X-ray or your CT.
Like a biopsy.
Biopsy, actually. I mean, both the bronchoscopy and the needle test are biopsies,
Okay.
just to get some cells for us to look at.
Okay. And the biopsy, the needle, that would definitely tell you whether I had lung cancer or not.
Well, again, it's not definite. It can't be too definite here.
Okay, so I've had the bronchoscopy and I've had this needle, and you still definitely don't know. What is your next step?
I think the chance of us knowing after a bronchoscopy and or a needle are extremely high, and I think we should just do those and take things from there, rather than worry about what we would do if they don't tell us. I think we could talk about that at that stage.
I just need to know.
I know you do. I know you need to know, and I need to know too, so that we can help you. But I think what we should do is do the bronchoscopy tomorrow. That'll give us a pretty good chance of finding out what we're dealing with here, and then go from there. That's what I think we should do.
What are the risks in a bronchoscopy or a biopsy, if you've got to go further?
In you, the risks are very small. You're an otherwise very healthy woman, and we would do this under a local anaesthetic, and we would have a look at this area of your lung and take a little piece of this tumour. Obviously, you've had a little bit of bleeding, so there is a risk of bleeding, but the risk of bleeding in you would be very small, and I wouldn't expect that to be a problem. And I think it's a very safe procedure in someone like you, and I'd have no hesitation in saying that that's what we should do.